So yesterday someone asked about the relative afferent pupillary defect and why you wouldn't get one in an occipital stroke. And in order to answer this question, you need to know a little bit about RAPD. And it's exactly what it says it is. It's a defect in the pupil pathway on the afferent side relative to the fellow eye. You need two eyes to test it, but you only need one working pupil. And the reason you need two eyes and one working pupil is we are comparing the relative light response from the direct response and the consensual response to light, and that is occurring at the dorsal midbrain. So the light hits the retina, the optic nerve, crosses in the chiasm nasally, uncrossed temporally, and right before we get to the lateral geniculate body, the pupil fiber comes off the optic tract and heads to the dorsal midbrain. So at the level of the dorsal midbrain, this is a pretectal neuron. This pretectal neuron occurs in the tectum. This is the tectum, this is the tegmentum, this is the basis. So in the midbrain, we're trying to get to the efferent pathway, which is the Edinger-Westphal nucleus of cranial nerve 3. And that'll get to the ganglion, and then that'll go to the pupil. So when we shine the light in either eye, the signal is actually felt in both Edinger-Westphal nucleus. And therefore, any lesion that affects the prechiasmatic pathway will have a relative decrease in the light from the affected eye on the afferent side, that's the sensory pathway to the brain, in the pupil pathway, and it's got to be a lesion or a defect. You can also have a lesion here in the optic tract, however, that also produces an RAPD because the afferent pathway is not just the anterior pathway, but includes the tract, and you can have an RAPD right here. That's a tectal RAPD from that pretectal neuron. So when we have an RAPD, it is a defect in the pupil pathway on the afferent side relative to the fellow eye. The occipital cortex produces a homonymous hemianopsia, but because the occipital cortex contains the fibers from the radiations and not the pupil pathway, even though an occipital lesion is a defect on the afferent side, it is not in the pupil pathway. And therefore, an occipital lobe lesion cannot produce an RAPD because there's no P. No pupil pathway goes there. And therefore, occipital lesion cannot produce RAPD.